Okay. We have Jake, Ken Anderson, Bill Franklin, Dennis Correa, Tom Van Zant, Jim Cameron, Paul Frieda. Who else do we have?
Frank Kelly.
Frank Kelly. Hello, Frank Kelly.
Hello.
Are you digging yourself out from under 10 feet of snow there?
Oh, we won't have daffodils and that stuff for another month and a half. It's so thick on the ground, it's frozen.
Really? Really?
Yep.
The
banks on the driveway are 5 feet tall.
Oh my.
You did it again.
Oh dear.
Gonna hang off and log off again. Sorry about that.
It's freezing rain, so it'll stay around for a long time.
Oh wow. That's not nice. We don't like that.
No, it isn't. Not at all, especially when the East Coast is having 60 and 70 degree weather.
That's right. Well, it was chilly here today. Let's see. Who else has joined us by telephone here?
Recurrent.
Hi, my name is Larry Fish, and this is the first time I'm joining the group.
Oh, great. Where are you calling from?
I'm in Brooklyn, New York.
Okay, and it's Larry Fishman?
Just Fish, F-I-S-H.
Oh, Larry Fish. Okay. And you're in Brooklyn. How'd you hear about us, Larry?
It was a long way. I mean, went to us two meetings in Maimonides in Brooklyn, Maimonides Cancer Care Center, and
right.
Then I came in through Inspire.
Oh, okay, excellent. Excellent, excellent. Well, welcome, and we'll give you a chance to tell yourself a little bit about us momentarily. Who else has come on by telephone?
Hey, Karen.
Hi, Jay. How are you? Bob,
Very good.
Jay, Bob J. J. Bob. Okay. And who are...
Jim here.
Jim. Hello, Jim.
For a while.
For a while. Are you leaving us
Okay.
soon? Are you off on your travels somewhere?
Yes, I'm on mobile.
Oh, okay. I see. You're on. Yes. We don't see you at all. I wonder if is Paul with us or not? Are you with us, Paul? Yes, not. Okay. Well, you can give us an update on. You can tell us how he's doing right now. That's always good to know. And anyone else on the telephone who hasn't identified themselves or would like to identify themselves? Okay. So I'm going to just again, I'll read down the list of the people that I know that are on the call. Jake Hannum, Ken Anderson, Bill Franklin, Dennis Correa, Tom Van Zant, Jim Cameron, Paul Frieda, Frank Kelly, Larry Fish, Jay Curran, Jim Marshall, anyone else? Oh, and Eric Bookbinder. Anyone else? Okay. So we have one new gentleman. We'll give you some time, Larry. Let me just run down the list and see who else would like to talk tonight. And so that'll just give us some idea of how to space out the time. Okay, Jake, anything you'd like to raise tonight? Jake? Well, yep. Can you hear me, Jake? He's having some trouble with it.
Yeah.
Oh.
I can hear you now.
Okay, good. Anything you'd like to talk about tonight?
No, Rick.
No? Okay.
I can't help you with the names either. Every time I try to do it, the computer, go to meeting crashes and I have to restart it.
Don't worry about it.
I don't know.
Equal of oxygen what?
Don't worry about it.
Okay.
Ken Anderson, can you hear us?
Yes, I can.
Oh, good. Okay. You want to give us a little update when we get, we'll come down to you, but you want to just give us a little update about how things are progressing for you?
Yes, sir, I can.
Okay, we'll come back to you. Bill Franklin, anything for you tonight?
No, I'm going to listen in.
Okay. Well, please do. Dennis Correa, you're going to give us a little update, and I'm going to introduce you to your Arizona neighbor. Well, kind of neighbor. If that's
Yeah, I'll give you a 2-minute update.
Thank you very much. Mr. Van Zant, hello. How are you?
Yeah. Hey, yeah, I'm doing real well. I just want to throw something at you real fast, and I don't think I'm going to stay on that long, but I saw the oncologist today. I'm on Zytiga.
Okay, well, I'll come to you first, okay?
All right, okay.
If you're not going to stay on that long, we'll come to you quickly, and then maybe even before we give Larry Fish some time. Jim Cameron, you want to give us an update on your...
I'll give you an update. Today I started the hyperbaric oxygen therapy, and 3 weeks ago I started the nerve stimulation for the burns on my bladder and the incontinence problems that I've been having.
Okay, so we'll definitely come back to you, and you can also tell us about your trip to Hopkins last week.
Will do.
Paul Frieda, anything for you?
No, nothing for me tonight.
Okay, Frank, how about you?
Not really anything unless somebody wants an update.
We all want an update. You know that. We all want to know how you're doing. We'll give you...
Okay.
You're in for an update. Okay. Larry, we're definitely gonna come to you. Jay, Bob, anything? Would you like to talk about anything tonight?
I was wondering what the guys thought of Firmagon versus Lupron.
Okay, we'll come Firmagon versus Lupron. We can talk about that for sure. Jim Marshall, I think, might have left us already, but he'll probably be back. I did get a quick note from Jim earlier on today telling me that the researcher that Sam Denmead mentioned a couple of weeks ago in Australia is actually working to put together a bipolar androgen therapy trial. That's all I know. I was hoping Jim might tell us a little more, but maybe maybe Sam heard those Australian accents and he moved into high gear there, so we could get something to them. Eric, anything for you? Eric Bookbinder.
No, I don't have anything today.
Okay. And has anybody joined us, or anybody whose name I haven't called would like to either introduce themselves or they have something that they'd like to talk about?
Rich Catapano joined in.
Ah, Rich Catapano. I'm glad we got you at the right time tonight, Mr. Catapano.
So am I.
Do you need to talk to us about anything tonight?
No, I think I'll listen in.
Okay. Anyone else? Okay. So, Tom, just talk to us quickly, and then we'll go to Larry Fish right after that.
Yeah, I visited the oncologist today, who shall remain unnamed. And because of what I heard on this call many times, I'm on Zytiga. And so I asked about possibly that it wasn't necessary to take 4 pills per day, or 1,000 milligrams. And without any hemming or hawing, he immediately agreed that you could take 1 pill a day with food.
Whoa.
And he told me, you go ahead and do that. Take 1 pill a day with food, and we'll see you in 3 months and see how you're doing.
Wow.
That shocked me.
Yeah, I mean, you know, that new research was only, I mean, we've known about this for quite a while, but the new research only came out like last month, I think, and it's interesting it's picked up steam so quickly. I wonder what I wonder what Janssen have got to say about that. It'd be interesting to see what their sales are. Anybody who's got Johnson & Johnson may want to short the stock, man. Wow, that's really something. Anybody else? Anyone else on the call talked about their Zytiga doses with their doc recently?
And by the way, I'm not recommending this to anyone. I'm just telling you what happened with me. Don't do it because I said.
Well, I mean, what's interesting is that, that to go from 4 to 1, I mean, you know, I know that most of the time they halve it when you take it with food, but I haven't heard them quarter it unless he felt that you wanted to reduce your dose anyway. But that's, I mean, it's good news, really.
Well, we'll see what happens. It surprised me. I'm dumbfounded that he did it, but he did it.
Tom, can I ask a question?
Please.
Tom, this is Jake. I'm just curious, did you ask him to do that? And was it because of financial reasons, or you were having side effects, or what?
No, it's not financial reasons because I get the drug free from the VA. In fact, in the back of my mind is maybe there'll be a way for someone who needs the drug because I'll have a lot extra. You know, I don't know about that. But no, it wasn't financial. And all I did is just bring the subject up. I was just there for my normal visit, and he volunteered it to me. As you know, I said I've been hearing just to see what he would say, and I thought he would say, well, that's not decided yet or whatever. And he said, yeah, you know what, just take one with food.
Wow, very interesting.
Is this your guy still at Fox Chase?
Yeah, the Fox Chase guy.
You like him?
Oh, yeah, he seems fine to me. Very knowledgeable. He's young, you know.
Right.
Nobody owns him.
No, I mean, I know that you've mentioned him before. I just want to be sure. I wondered if Steve, did you catch that, or did you come on after Tom started talking?
No, I didn't catch. I just joined just now.
Yeah. So Tom went in to see his doc for his 3-monthly checkup and was talking about possibly reducing his dosage of Zytiga, and the doc turned around and said, just take one with food instead of the 4 that you were taking before.
Yeah.
Volunteered.
There was that study that you sent out. I mean, that's certainly, you know, there's absorption with food, so I don't know.
Yeah. Well, thank you for letting us know. And the only thing that I would, if it were me, I would be doing is I'm not sure that I would, I would be testing every month just to see. Are you testing every month, Tom, or every 3 months?
Every 3 months.
I think I would probably get a test every month, just at least to see how you're doing on that, because you don't want it to get out of hand, you know?
Yeah, it's a good idea. Yeah.
Do you still need to take prednisone?
Yes.
Yes, okay.
But yeah.
Good luck with that, man. Good luck.
Yeah, we'll see what happens.
Yeah, but stay on top of it. Don't wait 3 months to keep tabs of how you respond to it, Tom.
That could be our little experiment here.
That's right. A trial of one.
The little lab rat.
Yeah, Dr. Bornstein can be the principal investigator. What do you think, Dr. B?
I'd like to cut back on the enzalutamide too. I mean, it seems like 4 of them a day, you know. I bet you 3 of them would work as well, or even 2. I don't know.
Well,
seems unusual to come up with a 4-pill-a-day dosage.
The enzalutamide is not absorbed through the liver, though, is it?
No.
No. All right. Well, that's excellent. So that's a nice start to the meeting. Very good. So before I go to Larry, Steve, did you have anything you wanted to talk about today?
No, there's nothing going on. I'm going to do some bloods on Friday, so I won't know anything till then. So
okay.
Going up to Tahoe tomorrow.
Oh, that's right.
Yeah.
Okay, so Larry Fish, welcome we extend a warm welcome to you in Brooklyn. And
Thank you.
We generally ask men who have not been on the call before to tell us a little bit about themselves, their age, their disease history, their disease demographics, what treatment they're going through, and then we have pretty knowledgeable Brains Trust on here. We're happy to brainstorm any issues you might have with your treatment or offer you any suggestions. Like you just heard, we've been talking for some time about playing around with the dosages on Zytiga. We've known for some time that Zytiga dose could be reduced if you took it with food, and then there was a study that we shared recently, and now we see a doctor who's picked up on it himself. And you know, when you're paying without insurance $9,000 a month for that drug, if you can manage with 25% of what you managed before, it can make a big difference. So go ahead, Larry. Tell us about yourself.
Okay. Well, I guess I was formally diagnosed just over 2 years ago. I had hip pain for quite a while. Thought it was a sports-related injury from jogging and a hernia plus something, but then eventually it was, I had my PSA out of nowhere, 228 or I think. I hadn't had it tested I'm 68, but I hadn't had it tested for about 3 years or 4 years. And it was normal, and then all of a sudden it was 228, and then prostate showed cancer and hip biopsy showed metastasis. And I had a Christmas tree for a bone scan. Mm-hmm. And I guess I started, Casadix and Lupron. I had a connection with my cousin, so I got to see this Dr. Kantoff, who's kind of famous in the field at Dana-Farber, before he left, Philip Kantoff, I guess his name is. Yeah. Before he went back to Sloan Kettering. I saw him one time, and that was just around the time he suggested adding docetaxel early, based on the two studies, the most recent second study had just recently finished. I was already out of that range, which was like in the first 4 months, but I did connect with a consultant at Sloan, an oncologist, prostate, urologist, oncologist, Karen Audio, who I also like. And she agreed with that, and then I would, how you say, you'd call unnamed, or I'm like a local oncologist, the guy I see regularly. I want to leave him unnamed because we just basically fight. He's just, but anyway, I started docetaxel. I was out of the range. It was already 7 months after I'd been diagnosed. I had 3 treatments, every 3 weeks. I guess I had my third, and I had a very bad reactions, and they suggested, everyone agreed I should stop, and I did at that time. Now, a year later, and my PSA has gone from 0.1 to 0.2 or something like 0.208. So I've started to become concerned at this point about what is on the forefront, what I should think about, how to put together what I should think about next, and like when I'm going to change oncologist to somebody who's more reasonable than my local guy. Is that, am I missing something? I'm still working, but I don't know how long that's going to go. The Lupron, I've been on Lupron and Casadix and bicalutamide, and that's been working fine for a while. I have all of the side effects that they talk about.
You do?
Yeah, I have almost all of them. I had hot flashes. I don't get much anymore, but a lot of weight gain, stiffness, aches and pains. I can't even think of, but basically the ones they talk about. Oh, I could wear a good size bra. My belly is pushed out. My my penis is disappearing, and
Right.
the usual, everything that they say, it's all true.
Are you still exercising?
I try to exercise as much as I can. That's sort of like, I think, my job is to try to exercise.
Right.
And I have to, if I go to the gym, I really have a longer recovery time. Used to be able to go every other day. Now I sort of need 3 days in between.
Right.
And I can't go. Sometimes I go to the gym and I just can't do it. I just say, I can't do this.
Right.
And I sort of, there's a certain point where I trust myself.
Right.
I have an elliptical in my apartment that I try to use.
Okay. So that's definitely a good move on your part to to try and use the elliptical or a stationary bike or something, and mix it up. Yeah, it sounds like the treatment path to date has been pretty much what most of the guys would have followed, but the fact that you only got through 3 docetaxel sessions, did you try a reduced? Did you try a lower dosage of docetaxel, like a half dosage every 2 weeks?
Yeah, no, we didn't discuss those options, and now I think I should have thought about them perhaps. It was because I was outside the range of the study. Nobody really knew,
Yeah.
but my PSA had gone down, and they said, just don't do this to yourself. And
yeah. Well, we'd be happy to give you some suggestions as to possible docs that you might be able to see in New York City. We've got a bunch of guys. I don't know that there's anybody on the call tonight who's being treated in Memorial Sloan Kettering, but we have a number of guys who are there.
Well, I have the person I see there who I really do like.
Oh, you do? And what's her name?
Yeah. Karen Audio, A-U-T-I-O.
A-U-D-I-O?
A-U-T is in Tom, I-O. It sounds audio, but it's audio.
Okay. A-U-T-I-O. And is she a medical oncologist?
Yeah, she is a urologist oncologist.
Yeah, well, but you see, you really need to be seeing a medical oncologist there.
Oh, she's a medical oncologist. Yeah, she is.
Oh, she is a medical oncologist.
Yes, she is.
Okay. Okay, well, I mean, if you like it, I haven't heard her name before. There's a number of people we know, but it's always good to hear another name that somebody likes. But if she's good and you like her and she's a genitourinary medical oncologist, definitely think about moving over, because you're going to get state-of-the-art treatment if you go over to the Memorial Sloan Kettering. Plus,
no, right. I hadn't done it yet because I was getting the treatment that she more or less said is okay to go along with. It wasn't exactly what she would have done. Mm-hmm. Locally, very convenient. They're sort of like around the corner practically, and it's sort of kind of comes annoying to work with in terms of logistics.
Right.
But I think I may have to start to switch. There's some other factors. If I'm maybe retiring or leaving my job,
right,
and then moving far away upstate. So I saw somebody in Binghamton, Dr. Ronald Harris, who I also liked.
Okay. We may. I think we could probably give you some names for. We could give you some names around Buffalo, but that's maybe too far away from where you're going to be.
Yeah, that would be too far. And how I came to Ronald Harris was that's somebody who Karen Audio worked with.
Okay, that's great too.
So it was that combination, and I like both of them.
Well, then that's really that's excellent. What I was going to say to you, if you can avail yourself of it, is that there are some good extra facilities at Memorial Sloan Kettering, in particular Donna Wilson, who runs a men's exercise program, and I can connect you to somebody who was much involved in establishing that program with her. He's one of our guys, Richard Foodie, and we have 3 or 4 guys that do attend that exercise program, and it's very good. And most of the guys that participate find it very helpful and useful. But overall, of course, Memorial Sloan Kettering, I mean, you're not going to do much better anywhere in the country. So if you can, we often tell guys that are in remote locations that if they can create a partnership between a local oncologist and a NCCN hospital, then that is the ideal. We discussed Ken Anderson, who will be speaking before too long. We had that discussion with him last week, and it's really an ideal situation if you can find that level of cooperation. Let me throw the conversation open to anybody that might like to talk to you, speak about your treatment, has questions for you. Anybody want to speak to Larry?
Sounds to me like he's responded quite well. If he had a PSA of over 200 and he's down now to 0.1 or 0.2, that's pretty damn good. Did you have your prostate removed, Larry?
No, they said, as my local guy said, oh, the cat is out of the bag.
Right. Even so, you know, with just the Lupron and the bicalutamide and the docetaxel, sounds like you're doing quite well.
Yeah, no, sorry. Yeah, it went very well. It's only just as my doctor, Karen Audio, said, is it was quite likely in over a few years that you would start to see the PSA start to rise. I just saw that start, so I started to get more involved.
When when was your PSA? When was it? How long did it take to go from 0.1 to 0.208, Larry?
It came down. It took a little while to come down. So let's say about a year, at least over a year.
Mm-hmm. And then you measured at 0.1. When was the last time you measured at 0.1?
Maybe 4 months, 3-4 months ago.
And then most recently, you're at 0.208, is right?
Right. I was getting it every 3 months.
Okay.
And then before I went to see this doctor in Binghamton, I had one about 2 months ago, 0.2 again.
I mean, like Jake says, it's staying nice and low. Yeah, it's starting to move. I spent 45 minutes talking to a guy up in just on the Canadian side in Niagara today who is looking at exactly the same situation. One thing that some of the docs do when it starts to move like that, and Jake can talk to you about this, is that they'll remove the Casedex because there is an effect where taking the Casedex away from you can bring your PSA down for a short period of time. I mean, the name of the game here is to manage and get the most out of every possible step that you're taking. So, Jake, you wanted to talk about the Casedex?
No.
Yeah. There's a bicalutamide is an anti-androgen, and once your PSA starts rising on it, there has been some research that shows that stopping it actually has a beneficial effect. Once it stops working, stopping it sometimes has a beneficial effect. They call it the anti-androgen withdrawal syndrome. It only works in about 30% of people, but it's certainly worth a trial. A try. 3 out of 10 people is better than 0 out of 10. I tried it. It did not work for me, but it's something that you might want to mention to your doctor.
Yeah, the doctor at Sloan had discussed that with me, Karen.
Okay.
Had talked about that. What can I say? I've been reading or hearing. I listened to some of the lectures from this group that were out. I mean, I listened to the BAT lecture, and I went back and listened to a couple of calls, a few others. I'm just trying to understand, like, when people are starting to talk about maybe starting Zytiga early or enzalutamide early. Is that something? I'm not at that point yet.
Steve, you want
I
to?
think that varies.
Yeah, no, I think other than the cost, and really that's dependent on your insurance, abiraterone and enzalutamide are clearly better than the Casodex in terms of the potency because it's an androgen receptor blocker. So even the minute amounts of androgen that are present after deprivation therapy coming from the adrenal or the testes, still the cancer cells are able to utilize that internally. So the AR blockers, the receptor blockers, and enzalutamide and abiraterone have different mechanism of action, so they don't work in the same way. I'm on enzalutamide. I started it quite early. I stopped the Casodex. Mine's kind of a screwy story the way this all unfolded, but I've been on it for about 5 months or so, and I feel that the side effects from the enzalutamide are probably about the same as the Casodex. I don't see it being terribly different. It's just more expensive. And so really that hinges on your insurance. And then, of course, when to throw in Provenge and radium-223 and some of the other things that it's really not clear what the best path is in terms of throwing those in. But it seems pretty clear that you want to throw them in at a point when your PSA is pretty low and the tumor burden is low. You don't want to wait until the tumor burden is too high. So those are other things that you want to sort of consider at some point.
When you say too high, what is the? I heard in some discussion people talking about 20 as being the end point.
Yeah, 20 is the number talked about, but your PSAs are so low at this point, so if that equates to a very low tumor burden, in other words, a low volume of actual cancer cells, Provenge, for example, might be more effective at this point than if they had a PSA of 20 or 40 or something like that. So I've just finished Provenge about a month or so ago. And says something else to consider. Again, it's contingent on your insurance and cost. I mean, these are all very, very expensive drugs. FDA approved, but very expensive.
Yeah, my insurance company is very kind of difficult, and my local oncologist, who I'm going to leave unnamed, as you say, he is, that's for much later, that's when, you're showing like a multiple repeat time and the PSA starts going up high like it used to be. That's when you start to think about second-line defense, and I'm going to think about second-line defense as early as I can possibly think about it in terms of insurance.
I would say that's true for Jeptana or a repeat dose of docetaxel, for sure, because of the side effects. I mean, you're talking a repeat course of chemo or going back on chemo, even Jeptana. To me, seems like that's the last thing you want to do. Having gone through both radium-223 and Provenge, at a point when my PSA was, in the 8, mine's about 8. The last time I measured it has been about 6 weeks now. But, I don't know. I don't think they're very effective if you wait too long. So I think that whole let's wait until you really need it philosophy is not a real good philosophy. It's not really based on any science. It's based on sort of, gossip and anecdotal opinions.
Yeah, I mean,
exactly why I'm on the call.
Okay, well, Larry, I mean, you are almost eligible for Provenge, because if you have 3 successive rises in your PSA whilst you're on LHRH drugs, then you are definitely eligible. It's FDA approved. Most insurance companies are paying for it right now. I don't know what your copay is, but it's pretty much accepted, and it's certainly something that you should raise with Karen Audio. I'm sure that knowing how, I shouldn't say knowing, but being familiar with how the Memorial Sloan Kettering docs often work with their patients. My guess is she'd be fairly supportive, but yeah, I mean, getting Provenge into you, the earlier the better, is a smart move.
Yeah, I'm gonna.
Go ahead.
I have an appointment with her in 2 weeks, and that's something I'll definitely be bringing up. I really want to thank all you guys, even right now, for all the time you're giving me.
Oh, it's a pleasure. Larry, would you like us to include you on the call notices that we send out before every call?
Definitely.
If you're not comfortable with giving me your, are you comfortable with giving me your email over here? If not, I can give you my email address. Just send me your email.
Yeah, no problem. I can give it to you. I did send something. You know, I don't know if I registered or they said if for the advanced group go to whatever that was, Cam, and I sent them a message and they sent me a message, and but the email I used was Zytiga, which is ITHAA. I, T is Tom, C is
You're breaking up a little bit. Just give it to me one more time. You broke up, I'm afraid.
Okay, it's Zytiga. I T
Yeah.
C is Charlie.
Yeah.
H is Harry.
Yeah.
K I don't even know what is in is Kiss. And A.
Okay.
ITHKA at AOL.com.
Okay. So we'll definitely add you to the list. We meet every week, 5 o'clock or 8 o'clock on first and third Mondays, and 6 o'clock Eastern time on second and fourth Tuesdays. And we'll add you to the list. You'll keep coming back. You'll tell us how you do with Karen Autio. You'll tell us how you fare in heading north up to Binghamton. You know, we hope we can continue to support you and give you good ideas.
Yeah, I hope this is going to be the beginning of a long relationship.
I hope so too. We all hope that. We all hope that. Okay. So let me just check here. Has anybody other than Steve joined the call in the last few minutes? Okay.
Yes, Bill Burhan's here.
Hey, Bill. How are you, Professor? That gentleman that we were just talking to, you heard, is thinking about moving up to Binghamton.
I know. I just caught that.
That's kind of up your way, isn't it? It's a little far, but
yeah, it's not too far.
Okay.
I mean, if he's looking for treatment at a comprehensive cancer center, I guess Roswell Park would be his closest.
Well, Larry has a good situation where he's got a medical, a GU med onc at Memorial Sloan Kettering who has a good relationship with the doctor, a local oncologist up around Binghamton, and they can work together, which is that's a nice position to be in.
Yeah, good.
So, okay. So, let's start moving down the list, and we'll kick off with Ken. Ken, you want to tell us how you managed this week? You might just want to give, some of the guys weren't on the call last week, so just give them a real quick update on your recent diagnosis and where you are. Tell us how you're doing this week and how we can help you.
You know, I'm not really sure about the helping part. I've got quite a bit going on in regards to getting my appointment scheduled at MD Anderson in Houston. Haven't really worked through the insurance yet. I will do, as you stated, though. I'll try to cover, a little bit of background. On the 20th or the 15th of February, I received a I noticed on my biopsies, which gave me a Gleason's 9. I've had the CAT scan and was informed that 3 appeared to be. I had the bone scan, and it appeared to have a number of areas that were suspicious, as stated on the pathology. So that's.
I don't know if everybody else, but you're kind of breaking up on me a bit. I don't know if you're talking away from the mic.
Same here.
I'll try to do better.
Okay, you're loud and clear when you talk right into the mic, but I think you're turning away from it or something.
Correct. So you want me to start from the beginning, or you want me to do what?
No, not for me. I mean, I've heard this before, but for anyone else, perhaps, I don't know.
Okay. Well, anyway, I'll summarize what I just stated. You know, I found that on the 15th of February that I have advanced prostate cancer, stage 4, 56 years old. I live in Arizona. What else? I've been trying to get, no, I've actually recently gotten an appointment at MD Anderson. So anyway, I'm going to go see Paul Korn on the 15th or the 16th of this month. I guess their procedures to start from scratch. They're going to take the pathology reports from both the CT scan and the bone scan and look at it, of course, but I was just looking at my schedule for the 16th. It appears that I have a series of kind of investigative type activity that to confirm what the pathology report actually.
Ken, you're cutting out again. This is Bill Burns.
I wonder why.
Do you have a headphone or with a mic, or how what are you talking into?
I was talking just like I did last time into a tablet.
I mean, whatever you're doing right now, it's great, but whatever, periodically it just goes away. Maybe it's just a weak connection through your tablet. I'm not sure.
I think what was happening is my hand was over the mic, and I'll keep it just the way it is right now.
Ah, that's
okay.
No, it's good. Whatever you're doing, just keep doing
that. You're clear as a bell right now.
So anyway, I'm working through insurance at the moment with Blue Cross Blue Shield.
Right.
I got a call today from MD Anderson. I don't know which. I mean, the lady's name is Vonda. She said basically that. Basically said if I come in and pay, because I had placed a call to them asking for clarification on acceptance on my insurance. I originally was told by Blue Cross Blue Shield that MD Anderson wasn't on the list of, places that I could go. So I called and kind of said, hey, I'm willing to sign up full boat. And I got a call today if I brought in the balance of my unpaid deductible when I show up that I will be considered a customer or patient or whatever they call me. So I'm planning on doing that. And they're going to start all over. It sounds like they're going to start all over doing tests,
When you say start all over, do you mean doing repeat? Didn't you have a radical prostatectomy?
No.
That's not on that. Yes, I did. That's not on the list.
Okay, so they're going to review the pathology as well as at this
Actually,
point?
the day after I talked to you guys a week ago, they had called or sent me a notice asking for permission to collect the information from a lab in Los Angeles that did the pathology on the biopsy. So I believe they've already requested whatever that is, whether it's the slides or I'm not sure what they get from this lab in LA.
Mm-hmm.
The doctor here, a urologist, sent the stuff off-site and got the pathology report. I didn't know what happened to the images of the cells. I don't know.
Right.
That's the proper terminology.
So I don't think, Steve, that Ken had surgery. He hasn't had any
I have my prostate removed. I had just the biopsies.
That's right.
Oh, I'm sorry. I remember last week, I thought you had said you'd had a radical prostatectomy a couple of years ago.
No.
Oh,
no.
just biopsies.
No.
Just biopsies.
Oh, yeah, okay. Yeah. So they'll send, what they do is they'll send the slides, basically, for the pathologist at MD Anderson to review.
Gotcha.
Ken, I'm really pleased to hear that Anderson's going to work with you on insurance. You know, when you and I spoke earlier in the week, or late last week, I should say, that was, I think we talked about that, and I had a feeling that if you were willing to pay them the 14 grand, that they would just go to bat for you with Blue Cross Blue Shield, because they know Blue Cross Blue Shield pretty well. I mean, they work with them all the time. So,
you know, I have to tell you, Richard, I did what you told me. That is, called in and said, hey, I want to go ahead and sign up. I left it at that because they didn't really say anything else. I just said, instead of going in for a consultation and paying $11, they would, you know, let me talk to this Dr. Korn,
right,
and give me, I don't know what they'd give me after a consultation, but then I called and said, hey, I want to come in as a patient, not as a consultation, and they said, you know, if you pay $9 grand or whatever the number is,
yeah,
when I go there, they'll take me as a patient. But they didn't really say that they were going to take Blue Cross Blue Shield. So I don't know if I'm out of network or in network. I don't really know.
My guess is that they will then just take over and work with Blue Cross Blue Shield. That's my guess. But you know,
There's no way that MD Anderson will not accept the Blues. I mean, it's a huge insurance company. I can't imagine that's not within a panel. So I wouldn't be too overly concerned about the insurance piece of it. The more important piece is the care, of course, you know.
Right. That's what I agree. I already told myself that if they weren't, Blue Cross wouldn't play ball, that I was just going to deal with the cost.
Okay.
You know,
well,
I don't know how. I was just going to do it.
I mean, you can always call their financial office, or visit with their financial office when you're down there, and you know, face to face go through with them. I think you're going to really like Paul Korn. Although I've never met him personally, from everything I've heard, he's a very compassionate, concerned, and smart doctor. And you know, he'd be up in my top 10 of all the doctors that we work with, or the guys that have been on this call have worked with. So I think you're going to feel really comfortable with him. As to the treatment path that he's going to set for you, I mean, it'll you know, we look forward to hearing what he's going to suggest. Probably chemo is in your near future. If you can do that through MD Anderson in Mesa, that would be terrific. I don't know what their current thinking is on debulking the cancer. It's a question I would definitely want to ask him. I'm happy to work with you to try and prepare some questions if you feel that that's helpful. But you should have a bunch of questions ready for that meeting, written out and ready to hand him, so that you're sure that you have everything covered.
I don't know what I don't know.
The other thing, Ken, to consider, which we talk about on this call, is to record the meeting. So, you know, take your tablet or your phone in with you and let him know, and that way, I'm thinking you're going to be going on your own, or is somebody going with you?
You know, I've had lots of people offer to go, but I decided to go by myself.
And why? Tell us why.
I don't really have a real good answer, honestly. I mean, both my sisters have offered. I haven't told my mom yet.
Mm-hmm.
I have a couple clients that are older guys that they said they would go. I mean, the burden on them is quite a lot, I think.
Mm-hmm.
I don't know. I mean, I just, you know, I'm single. I've been single for my whole life. You know? So the fact that I'm used to doing stuff on my own, I travel by myself because I like to come and go when I want to come and go.
Right.
You know, I like to.
Right.
No, it's. I don't know if it's complicated or it's just me, but that's kind of what I decided.
You know, Ken just as a physician for 30-something years, I think if people who are close to you, your sisters, clients, especially if they have a medical background, if they've offered to go on the first visit, I would have them go. There's been studies to show that you retain about 20% of what's discussed, which is why Rick is discussing, you know, bringing something to record it. But make sure you ask anybody you're recording if it's okay to record that conversation. Don't just do it. But I would say, given that you'll remember about 20% of what was discussed, having another set of ears there is a great idea for that first visit.
And Ken, I mean, you're talking to somebody in the same boat as you. I mean, I've always been single, and I also resist taking people along with me. But we just know from experience that if you're better off having someone with you to take the notes, to make sure all the questions get answered. Another set of ears, especially the first time you're in there, is really important. Anybody else want to address that on the call?
Well, I would never go anywhere without my wife. How's that?
Oh, I know. I don't have a wife. I just told you, I'm single. I have a wife.
Well, it's okay.
You don't need to have a wife. You don't need to have a wife. You just need to have somebody that's a good set of ears that listens carefully.
Right, and I've heard that Frank's wife does such a great job. She may even rent out to go to medical appointments with other people. I don't know.
Yeah.
But no, I mean seriously. I think if you can take somebody. I mean, I often go with people, especially if it's in the Bay Area, and you know, even if it's beyond the Bay Area, I've been known to attend appointments with people. And then, you know, when I go, my job is basically to take good notes to make sure everything gets covered. And I really feel that if you can get somebody to go with you to that first corn meeting and then see after that. But if it were me, knowing what I know now, I'd be taking somebody with me.
Well, I have to tell all of you I appreciate the comments. I don't know which way I'll go at the moment. I still have, you know, a week to decide. Luckily, I have a little bit of time, and I just don't know who it would be. I can't put my two sisters because they both work. You know, I can't take them and tell them, and they've offered, but I'm not going to do it. I know I'm going to tell my mom on the 9th, and she just had surgery, and her sister is coming from South Dakota to be with her when I tell her.
Mm-hmm.
Well, ultimately, Ken, it's up to you. I'm just saying that if you choose not to bring somebody with you, make sure you write things down, record it, because it's, you know, there's going to be a lot of things discussed, and you know, you don't want to have things fly by you and you know, and not quite remember what he said. So I do think that having another set of ears there is a wise idea. But if you go alone, just, you know, record it. Just ask if you record it, and then listen to what was said.
Okay. I will definitely give it all a little consideration.
And you know, there is one other option, which is which I've done, is that you can have somebody attend virtually by arranging ahead of time to have them dial in, or for you to dial them into the conversation, so they can listen in with you without being actually in the room with you. I mean, I've done that a number of times. So you have
like put it on or something.
Yep. I mean, it's not as good, but it works. And you know, it is overwhelming for you. I mean, you recognize that, and you know, if you have a moment where you feel more overwhelmed, you might miss something really important, or your mind wanders, and so that's why all of the above, everything that's been suggested, I think, and not just for you, everybody who's listening on the call, it's important for everybody to be sure that you cover, but especially when you go in for a first appointment and You know, you're still in shock, and so you should be. So
one last suggestion. When I went for my second opinion up at Mayo Clinic, I asked them specifically for a written report of everything that we would discuss, and they did provide that.
That's good, Dennis.
Yeah, I was just about to suggest the same thing. I routinely ask for a copy of the clinical notes that are written by the clinicians at these meetings.
Yeah, you know, if it's, I assume they have an electronic medical record, and typically there's a section called patient instructions where you can, you know, say, well, these are the key points. It takes a little work on the physician's part to do that, but it's your right to get the actual note itself, the commentary in the note itself. That medical record is certainly something you should have access to. You need to actually request it, but it's a document that's not privileged. You have the right to see it. Sometimes it's a little cryptic as to what's being said because it's a lot of medical jargon, however.
Right. Well,
But if you,
I'll take your advice about taking someone, and I'm not sure that it's possible. You know, it's not, because they're saying it's, you know, I get there on the 15th, and they're saying as much as 5 working days. So for me, it's Thursday, Friday, Monday, Tuesday, Wednesday. And that means whoever goes with me, I got to ask them to give up. I mean, I think it's a lot to ask if they're not a spouse.
Mm.
You're breaking up again.
I know, I put my hand over the speaker. Sorry about that. I think it's a lot to ask if it's not a spouse.
Yeah.
You know, a client, I'm going to ask a client or someone that I've known 20 years, you know, someone that's 80 that has prostate cancer offered to go. It's like, no, he's here on vacation. I'm not going to take him to Houston even though he offered. And I'm not going to do it. I'm just not going to do it.
I understand what you're saying, Ken. I think you're in a tough spot.
Yeah, you do whatever you're most comfortable with, for sure. I think the bottom line is you want to walk out of there with a good understanding of what they're suggesting and the alternatives and the risks and so on. And so my own bias is that another set of ears is always useful, but, you know, I mean, just listen very carefully to what's being discussed, and if you can record it, certainly do that.
Well, I absolutely, as long as they're okay with me recording it, I will.
Yeah, I think if you ask them, they will be. I think sometimes if you just go in there with a recorder, sometimes that's, you know, it's not looked upon very well.
I would also recommend that you make a list of, spend some time before you meet with them thinking of questions, and then make a list of those questions and to ask when you are at the meeting.
Well, how in the heck do you know what kind of questions they asked? I just barely know what the disease. I know what it is.
Well,
I don't.
You work
know.
with, you work with people like us, Ken. That's why we're here. So we can go through, we can talk to you about what the questions are, what you need to know. I mean, we've got some standard, I've got a list of standard questions, but we've done it enough before that we can help you through that if you want it.
Yeah, I do. I mean, if I know, I mean, I've been reading like crazy, so I have lots of questions, but I have to tell you, most of them I think are, I say stupid questions, but it's like, what is, I mean, my questions are, someone tells me I should be taking X, Y, Z. I have a lady that's a homeopathic doctor, and she's got this whole list of stuff that I should ask. It's like 3 pages. I can't possibly ask this guy after I've just met him 3 pages of just crap.
No, you don't want to inundate somebody. You know, I think, you know, I used to see patients, they have a list of 20 things they want to cover, and I would say, well, you know, we have time for the first 3 today.
Right.
And so I think what you want to do is refine it down to the most important questions. But the other thing is if they start to suggest treatment, you want to look at, you know, the benefits of the treatment, especially in terms of survival benefits, side effects, treatment, alternatives to treatment, and then the risks of treatment as well. Those 3 things, they call them the BARs, B-A-R, benefits, alternatives, and risks. those are kind of the key pieces that you want to kind of cover. If they say we're going to start you on docetaxel, well, what are the benefits, survival benefits, et cetera? What are the alternatives to doing this, and what are the risks of doing this? And then usually you get some pretty concise answers with that.
This will be to Dr. Korn, I assume, not to this. This is to MD Anderson. Is what you're telling me? Use this bar thing to discuss.
Yeah, I mean, oftentimes in a teaching setting, you may be seeing a fellow as well. So it may not be he and he only, but it doesn't matter if you're talking to a nurse practitioner or anyone else. If somebody's suggesting to you, well, we're going to start you on, let's just say, docetaxel at this point, you want to have a pretty good understanding of the benefits, alternatives, and risks. That's just those. Just kind of keep that in mind if they suggest any treatment, and then you're going to cover most of the ground with those questions.
Yeah. All right.
Well, I would very definitely come back to us with any questions that you have. Call it. The next time we have one of these meetings after you've been meeting with all these doctors, I think that there are plenty of people on this call that can help you sort through the various options and just answer questions that you have.
Okay, thank you.
Ken, I mean, again, if you want to do some personal navigation, just let me know, and I'll take the time and we'll work something out. We can go through the questions. We can figure out how to get you covered. But like I say, we've seen it before, and that's what allows us to make it easier for you.
Okay, I'll take your comments for sure, and I will reach out. I know Wednesday I'm having lunch with some guy here in Phoenix that does exactly kind of what I'm planning on doing. That he goes to MD Anderson. He's been going there for 5 years, and he's seen logothetists as a doctor, but I'm planning on using his experience, or at least allowing him to explain his experience to me.
Okay.
To navigate. But after that meeting, I'll have questions definitely for you, Richard. So I'll reach out. I'll give you a call.
Okay.
Thursday.
Okay, that sounds good. All right, Ken. So hang in. May the force be with you, and let's get through the 15th or the 16th with Korn, and then see how you go. I think after you've seen Dr. Korn, my guess is you're going to feel that there's a big weight off of your mind, and you'll feel that you're part of a team that's really concerned about caring for you. And but we'll see.
Look, I'll be in touch.
Okay. So Dennis Correa, who is down the road from you in Tucson and sees GU Medonc at University of Arizona. Dennis, you're up. Tell us about your most recent trip, your hospital visit.
Yeah, I just met with my medical oncologist here last week with my routine 3-month follow-up appointments. But just background this, I just passed my 1-year anniversary of my initial biopsy and diagnosis with a Gleason 9. And then subsequently to that, all the other tests and so forth, and found out, metastatic stage 4 advanced prostate cancer right out of the blue sky, because I've been going every year and have my PSA tested, and it was fine until you went above 4, and then proceeded with the urologist to get the test done. But since then went through the docetaxel and Firmagon, which was recommended by Dr. Parminder Singh, who was, when I did my research for where I wanted to get my treatment, and staying in the Tucson area without having to travel, he was the guy that kept coming back from every resource that I looked into, and he wanted to start me immediately that day on the Firmagon as the first dose of the ADT to prevent the tumor flare. And then came back in and made another appointment for the docetaxel. So I started them basically both of them together simultaneously, and I did have difficulty getting through the docetaxel. Ended up in the hospital for 5 days with the low white blood count, and they took care of that and got back on, finished the treatment schedule. But now I'm at the point, I'm still not considered to be castrate-resistant prostate cancer. In other words, everything worked. It dropped me down less than 1 on the PSA, and I'm so far staying there. My last analysis was at 0.98, which is getting up there or closer, but it's still pretty much a flat line. It's on a very slow increase, less than about a point or so every 3 months that I'm going up. So I don't know if anybody out there has anything to how they formally define that castrate resistant, at what level of PSA. My doc is telling me about 3, and then we might need to look at something else. But that might be a couple years out if I maintain the same rate of, progression that I'm on now, response to the Lupron, which we switched over to after the first dose of the Firmagon.
I mean, usually with this isn't recurrent disease, and we're not talking about intervening. I mean, if you've had 3 successive increases in your PSA whilst you are on Lupron, you are castrate resistant. Now, the question as to when do you intervene and what you intervene with, that's a whole nother discussion. That was the discussion we were having with Larry Fish. Oh, and by the way, Larry, as you heard, Dennis had problems with the with his chemo, with his docetaxel after 3 or 4 sessions. And Dennis, didn't they reduce the amount of chemo? Didn't they?
Yeah, they reduced the dose slightly and also put me on the day after injection.
Right.
Can't remember the name of the stuff.
Neulasta.
Neulasta, yeah, and that helped.
Right.
But I'm not really having any symptoms yet. I'm doing fine, other than the stiffness from the Lupron side effects. That's the primary thing that bothers me. But I find the more that I keep moving every day, once I'm up and moving, it's not so bad. I just finished 18 holes of golf today, so.
I was just going to ask you, how often are you playing golf?
Twice a week.
Twice a week. Well, we've got a very good golf game for you, partner, in Venice, Florida. If we could make a match somehow between Tucson and Venice, Florida, we could get a good golf game going, right, Mr. Cameron?
Yes, we could.
Sounds good.
Matter of fact, I played this morning myself.
This question as to when are you castrate resistant, I think it's the wrong question. I don't know. Jim Marshall, what do you have to say about that one?
Here we go. Can you hear me?
We can hear you.
Not much very useful. I mean, the definition of castrate resistant is quite clear. Your PSA is going up while your testosterone is removed. You hope that the doctor is checking that your testosterone has been removed, and not that you need a little bit more hormone. You don't want to move on to other treatments when you don't need it. But if you're sure that the testosterone is gone and the PSA goes up, you are hormone resistant. What you do then is down to the art of the doctor, really. There's no clear guidance as to when you start hormone therapy. I missed the start of this story. Rick, this guy has recurred or walking off the street like this?
No, not recurrent.
Dennis was diagnosed about a year ago with metastasized disease. Went through docetaxel. It brought his PSA down. I can't remember, Dennis. What was it? What was your PSA when you were diagnosed? It wasn't that high, was it?
Like 17 or something.
Yeah.
20. I've had so many numbers I've forgotten them all.
Yeah, I mean it wasn't that high.
And then it knocked it down to less than 1.
Right.
And it's still less than 1 after 9 months.
Right. But it's starting to climb.
Okay. Okay, so doctors here would be probably looking at the rate of climb and switching to cabazitaxel, Jevtana, to see how that goes. And the good news is reaction to Jevtana, although it's a cousin of docetaxel, is fairly independent. That means that even if you didn't get a great response to docetaxel, you can still get a good response to Jevtana. One of our members has had 40 Jevtana infusions so far over the last, I don't know, you have to multiply 40 by 3 weeks, couple of years.
You know, and so I think that waiting until you get to 3, I don't know. I mean, if you creep up very, very slowly, maybe it is a good strategy. I think the rate of increase, as Jim mentions, is really important. And the other thing, like we said with Larry Fish, is that you want to open up this discussion about Provenge, because the earlier you do the Provenge, the better you are. You know, there is another drug coming down the pike. Probably there's a good chance it'll get approved sometime this year, called Prosvac. But it's a complementary drug to Provenge. There's no reason why you can't do both of them. But I think that if it were me, I'd be talking to Dr. Singh about Provenge right now, because as Dr. Steve said just before, the earlier you can get that into you and the lower the tumor burden, the more likely it is to be successful and to prolong your overall survival. So
yeah, I think the other thing is that something like that is preferable to starting on a new chemotherapeutic, whether it be Jevtana or docetaxel or platinum-based or whatever. It's just, you know, it's pretty simple. It's, you know, 6 appointments over about a month and you're done. So I certainly would. Most oncologists really they disfavor it because of the cost and the difficulty in terms of the logistics of, you know, doing Provenge, but I think those are the only reasons. Other than that, I think it's a solid drug. And when Prosvac does get approved, which is, as Rick says, very likely pretty soon, certainly by this year, if not by the middle of this year, I think Prosvac may overtake Provenge, and it may not find it to be something people do anymore because of the costs and the difficulty of administering it versus Prosvac, which is just sort of like getting a polio vaccine. Basically, it's just an over-the-counter, you know, just an injection pretty much, and that's it. So, you know, I do think that that's another alternative to think about.
Yeah. Okay.
So, you know, have a chat. I mean, I don't know that I would wait 3 months. You know, send a note to Dr. Singh, tell him you'd like to have a chat with him on the phone, and say to him, look, you know, what about considering Provenge right now, and see where you go with that.
Yeah. Yeah. Okay.
Okay.
Sounds like something I can try.
Okay. Anybody else? Anybody else want to?
What's surprising is my current oncologist he just seems so pleased and happy with my result again this month. You know.
Well,
and
you know, it's an interesting observation. I mean, I'm sure he's happy because the disease is holding where it is. But then the real question is, how aggressive do you want to be in treating that disease? I mean, we've got people on this call like Steve who, you know, believe that you throw everything at it. We've got other people who are more happy to sit back and see where it goes. A lot of it is your own personality. I mean, I know what I would do, but I'm not you.
Anybody the other thing is you don't want to be dealing with the side effects from your treatments being worse than your disease. I mean, that's a very undesirable situation when basically you would have felt very well except for the treatments, because none of these things are guaranteed to work, you know, and so I think you have to take that into
that's exactly where I'm at, because, you know, when I got my diagnosis, I didn't have any symptoms, I didn't have any problems, and when I really started to go downhill was during the treatment.
Right.
You know, with the chemo and the Lupron, I feel like I've aged 10 years.
Yeah, it's unfortunate that,
you know, if something else is going to make me feel worse than I do now, and it better be darn good.
Yeah, I think that's a good attitude to have, you know, and unless there's a pretty good guarantee that it's going to improve your quality of life or length of your life, you know, if you're feeling pretty good, I'd be hesitant to try anything with your numbers, frankly. I think watching it is not a bad thing.
Well, I mean, I will say, though, that for most men, the vast majority of men, Provenge really doesn't have too many side effects. It's not the most convenient protocol, as Steve will tell you, but in terms of side effects, it's really pretty low, wouldn't you say, Steve?
Yeah, no, it's, you know, once I got used to the idea, I had to schlep to Oakland, California, which is across the Bay Bridge for me at 6 in the morning, because my appointment was at 7 with the Red Cross. You know, and then afterwards, so it was 3 hours, and you sit there with these IVs, and I had an audio book, and I listened to it, basically, and then my wife and I would go over to Pete's and get a coffee afterwards and a scone and sit around for a little while, and then schlep back across the Bay Bridge. It wasn't so bad. It was a chance for me and my wife to kind of sit around and talk for 3 hours without any distractions. So that was good. That was a good thing, I guess. As you know, Rick, my wife can talk, as you know.
and you know, there are a lot of guys that have done Provenge on this call, and so if you want some more comfort and hear some more stories about how people got on with Provenge, then we can make that available to you. But I think something that's worth, if it were me, I would be talking to my doc about it. I know that.
Mm-hmm. Okay. Well, thank you very much, everyone.
Okay. Anybody else want to say anything to Dennis? Ask him about his handicap or anything else? What clubs he uses?
I had a comment about Provenge.
Go ahead.
I went to a couple different oncologists before I wound up getting Provenge, and they at those hospitals didn't offer it at the time, but they told me if you can ever get it, absolutely get it.
Yeah.
Now this is about 2 years ago, but that was their opinion. Just two different oncologists. One of them was Sloan Kettering. You know, they were saying if you get the chance to get Provenge, get it. So I did eventually get it. I don't have any side effects at all from it. I don't know if it did me any good.
Well, that's right. That's the whole thing. You don't know if it does any good because it doesn't really change your PSAs. But you know, I think the cost is so prohibitive. It went from $90,000 to $103,000 this year. You know, so it's prohibitively expensive, and that's just the 3 treatments. You know, that's it. So pretty expensive stuff.
Well,
I say.
It is, but by and large, I think the insurance companies cover it.
Yeah, no, the oncologist I saw, Santa Clara Kaiser, I said, boy, this stuff is expensive, and she said, well, you're well worth it, you know. So that's all good, I guess.
I'm on Medicare. Do you know they cover it?
They do cover it, definitely.
Yes, definitely.
Definitely, they do.
I didn't pay a penny for it.
Yeah. Yeah, I think you'll find that they do cover it, and you have a supplementary policy, right, Dennis?
Yes. Yes, I do.
Yeah, I think you'll find that it's covered.
Yeah, it's because it's done, the infusions are done in a hospital ambulatory surgery setting, so-called HAS setting. It's covered by Medicare completely. So you shouldn't pay anything.
Right.
But on the other hand, the company does charge $103,000 to your insurance provider, so it's pretty costly.
Yeah, I mean, I'm
Sure.
talking to the guy that I'm helping up in Canada, and he does have a problem because they don't cover it in Canada, and he's trying to figure out how he could access it. And he has a situation very similar to yours. His PSA has started to climb up. It's gone from about 0.1 to about 0.3. He had his chemo about a year ago. I mean, it's very similar to Larry, very similar to yourself. And he's looking what to do next. But you know, he unlike you and Larry cannot easily access Provenge.
And the other thing is, you know, with Trump being in office now and looking at the costs of drugs, this is a prime example of, you know, the clinical trials showed 3 or 4 months of survival benefit. And I do think that information is flawed because it looked at all comers. Depending on your PSA level, you did much better with a PSA less than 20, but I wouldn't be at all surprised if you find drugs like Provenge are no longer available because they're cost prohibitive or they become a large out-of-pocket. So I would get it sooner rather than later in the United States.
And like Steve said, I mean, the 4 months which gets bandied around is an average number, and I think the men who got it earlier, and they really haven't done or published any results on men who got Provenge early in the disease path, or at least nothing that I've seen. But it makes a much more significant difference than the 4 months is my guess.
Right.
All right, we're going to move on,
Great.
and we're going to talk to Jim Cameron, who was if I remember, at Johns Hopkins for several appointments in the last week or so, and has started some interesting treatment for his for the bladder issues. Jim, you're up. You with us, Jim?
Rick?
Yes, we can hear you.
Okay. I'll start with today was the first day of my hyperbaric oxygen treatment.
Right.
I sat 2 hours in the tube, and it wasn't really bad at all. You don't feel it. You don't really feel anything. But I got 39 more treatments to go.
Uh-huh.
And that's because when I had my radiation 12 years ago at Sloan Kettering, my bladder got burned, and now I'm having problems occasionally with bleeding. Mm-hmm. And when they looked in at my bladder, they say about half my bladder is burned.
Mm-hmm.
So I started that, like I say, started that today. I got 39 more days to look forward to. Mm-hmm. And 3 weeks ago, I started the nerve stimulation, where they stick a needle in your ankle into a nerve that goes up to your bladder, and for a half an hour they run a current up to your bladder to stimulate your bladder, and that's because I'm always feeling like I have to hit the head, mm-hmm. And it's supposed to calm the bladder down.
And have you noticed any difference, Jim?
I only had 2 treatments so far, because last week, like you mentioned, I was up at Johns Hopkins, and the nerve stimulation is a 12-week cycle.
Okay.
And they told me usually about session 6 or 7, you should start to notice some improvement. And if you don't, they may even opt to abandon the treatment that it's not working for you.
So we've had a guy, he doesn't come on these calls very much, but he's a good buddy of mine. Steve has met him, his name is Steve Brown. And he has been doing these treatments for a long time, and has now reduced it to about, I think he now does once every 3 months, but initially he had a heck of a problem with urgency. and it was very successful with him. I'd be more than happy to introduce the two of you, and you can talk to him on the phone.
I've talked to a couple people that have had it done, and everybody I talked to said they've had some success with the nerve stimulation.
Right. Yeah.
I didn't hesitate to start that because it's a half an hour. You sit there for a half an hour with the stimulation, and it's once a week. And I got a urologist here in Venice. I just go to his office on Friday afternoons, and they're not injecting anything into my body, so I figure, it should be fairly safe.
Right. And both the hyperbaric and the this nerve stimulation, are they both covered by your insurance?
Yes, they are.
Okay. Okay, and that's Medicare plus supplementary, right?
Right. Yeah, I have AARP, and yes, they are covered. I was surprised when I started looking around to see where these centers were. There must be 80 of these. Most of them are in wound centers. This treatment's used a lot for people with wounds that won't heal. Diabetic wounds, burns.
Professor Bill.
In Florida alone, there had to be about 80 centers.
Professor Bill, I feel like you should be chiming in here, or at least maybe have some questions or some thoughts.
Yeah, so I considered hyperbaric oxygen treatment for the same problem, radiation cystitis, that was accompanied by a fair amount of bleeding as well. But I opted not to do it, partly because the urologist that's been treating me indicated that she was skeptical about how well it would work. I have had other treatments, including bladder installations, which involves introducing a solution into my bladder of it's the solution. There are different cocktails that are used. The one that that they've been using on me is a mixture of heparin and lidocaine, and I think just a salt solution. And that has helped with the pain, and it also has helped with the urgency. I also had a Botox injection, and I think that's helped as well. But I haven't had the hyperbaric oxygen treatment, and so I'll be interested to know, how it works for you.
I talked to two guys that had the treatment done.
Yeah.
And they said, one said he had completely stopped bleeding, and the pain went away. The other guy said he had about he had about an 80 or 90% success rate after completing the 40 sessions. To me, the difficult decision was that you have to sit in the tube for 40 consecutive days, 2 hours.
Right.
And I was total there today. By the time I got there, changed, sat in the tube, and they check you out first, and when you come out of the tube, the doctor checks you out again. So you're there 3.5 to 4 hours. That's for the next 2.5 months. That's a big commitment.
That was a big consideration for me as well. And on top of that, at the time that I was discussing this with my urologist, I told her that I was willing to consider this, but only if my prognosis was long enough so that I wouldn't be spending the last few months of my life sitting in the hyperbaric oxygen chamber. And so at the time, my prognosis was dismal. And that was another reason why I decided not to do it. That's changed since then. I've I've been taking an experimental drug that I'll be talking about at some point in the future, I'm sure.
Yay.
That has had dramatic effects, and so my prognosis is actually quite a bit longer now. So I made, if you know, I'll be very interested to see how this works for you.
Well, I'll keep you updated.
Okay, but I would also encourage you to ask about bladder installations in particular. They worked pretty well for me. You know, I can let you know what the specific cocktail was that they used for me. There are other, as I said earlier, there are other formulations of these cocktails that might work even better. But I would definitely bring it up.
Yeah, next time I'm going to the urologist, I like to have some information on that. The only thing, sure. He didn't mention anything about any of those cocktails. He did mention the Botox treatment. He said he has a few patients that are on the Botox, but he told me the Botox have to be injected every 6 months.
Right, that's correct. And that's it's you know that's I'm willing to you know to go forward with that. It's not a terrible inconvenience. I mean, it involves I think it required a cystoscopy the first time that they did it. I don't know if that's going to be required every time, but you know, I've had so many cystoscopies now that you know it's not something that is a big problem for me.
He told me you had to be admitted to the hospital and you had to be put under to have these shots done.
You do have to go under general anesthesia. At least I did. Actually, I don't. They put me under general anesthesia because there were other issues that they were dealing with at the same time. So I don't. I'm a little bit surprised to hear that they would do that just for a Botox injection, but that's what you learned.
Well, you got to remember, I'm down here in Venice, Florida, and there's very few people under 65 years old down here. So they're dealing with an older a much older population generally.
Yeah, okay, that's a good point. Despite the fact that you know, I had general anesthesia, they discharged me at the end of the day. I didn't have to. They didn't actually admit me into the hospital.
Like I said, it was a hard decision on my part what to do, but I checked with 3 different oxygen centers because I also spend the summers up in New Jersey, and I checked with one up there too. And of course, they're trying to sell the services. All 3 of them told me they have about a 90% success rate.
Yeah. Okay. I mean,
so
I think.
But if it fixes the problem for you know, a long period of time, I guess I'm willing to do it.
Yeah, I think, you know, in my case, the biggest problem is pain. And, you know, at this point, I'm willing to do anything to mitigate that particular problem.
Mine's just, I really don't have any pain. It's just that every now and then when I bleed, to me it's a very uncomfortable feeling to stand there and bleed.
Yeah. So it's a fairly large volume of blood?
Once in a while, yes. You know, it's a steady stream. And that's only started recently. Before that, it was just a drop here or a drop there. But in the last couple of months, it's gotten worse.
Yeah, that's. I mean, it was. I remember the first time that this happened, and nothing came out except for blood, and it was extremely disconcerting.
Yes, yeah.
But
that happens to me. It's very
But aside from how disconcerting it is, it's a pretty serious problem, and it, you know, I think I'm, once again, I'm willing to do whatever it takes to fix the problem. I mean, hemorrhagic radiation cystitis can be deadly.
Have you, Bill? Have you? Do you suffer from emergency problems? And if so, have you considered the electro acupuncture or the nerve stimulation?
I do have urgency problems, but I have not considered that. No. Mostly because I'm doing all these other things, and I just there's only so many minutes to the day.
Well, I mean, it is pretty benign. It's a once a week session, and like I say, I'd be more than happy to connect you to Steve Brown because he is the expert. He gets the treatment from a guy called Starler, Howard Starler, who's a vice chairman of urology at UCSF, who was one of the originators of the treatment, and he has had a lot of luck with it. So it is something worth thinking about.
Yeah, okay, definitely. If you could send me the contact information for this fellow.
I'm making notes of who I have to connect after this call, and I will connect you to Steve Brown because he's
terrific.
Very happy to share his knowledge with you. So I'm going to move on if that's okay. Is there any? Oh no, there is something else. Just tell us how you did at Johns Hopkins. Then.
Yeah, I was going to say you can give me another minute.
We'll give you a minute.
I was up Johns Hopkins all last week. I saw the eye surgeon that did the surgery on my eye, and I'll make it short. Everything's going real well there, and they checked me for melanoma because that was a melanoma tumor. Everything's going fine there. I had a CT scan of for my prostate. The lymph nodes that were swollen last time have all gone back to normal, they said. But the bad part is there's a 5 millimeter, you called it mass, on top of my prostate. Now, I had been on intermittent Trelstar. Last Wednesday, they gave me a shot of Trelstar up there, and Dr. Carlucci, my doctor up there, he thinks that when I'm back on the Trelstar, that will reduce that mass. So I have to wait. Of course, I have to wait and see now. But he said going forward, there's a good possibility I'll have to be on Trelstar forever and get off the intermittent. I'm a little concerned about the 5 millimeter mass on my prostate.
Right. What was your PSA?
PSA was 5.6.
Okay.
Because the way they were doing the intermittent was they drive it down below 1. They drive my PSA down below 1. When it gets below 1, they take me off the Trelstar. When it goes back up over 5, they put me back on the Trelstar. Mm-hmm. And usually it takes about 10 months to go from 0 point something up to 5.
Mm-hmm. Mm-hmm. And there was some more recent research. I think I sent it to you about the continuous versus the intermittent. If not, I will send it to you. I know.
I got that piece a while back from you, Rick. I have that. Thank you.
And by and large, it seems like the continuous is better, but it's not super clear. But then you have to offset that against the quality of life advantages.
Well, I'm fortunate when I'm on Trelstar. The only side effect I have is fatigue. I got to force myself to get out and do things.
Right.
But I don't have any. Fortunately, for the last 2.5 years I've been on it, I have not had any of the other side effects.
Did Carlucci say why he didn't put you on Casedex before putting you back on the Trelstar? I mean, I find that a little strange.
I didn't know enough to ask him that, and he didn't mention it. He just sent me upstairs to get infused with the Trelstar.
Yeah, to get a shot. It's a shot, right?
It's a shot in the butt. Yes.
Yeah, I mean, you know, I don't know. It seems to me that the Trelstar gives you it's an agonist, so it gives you a boost in your testosterone before the testosterone shuts off, and you know, when you've got a man that is at risk for metastasis as you are, one would have thought that you would use the buffer of Casedex beforehand. I would say to anybody that's on intermittent, when you go back, unless they're using Firmagon, and we'll get to that discussion in a moment, but unless they're going to give you a shot of Firmagon, and you're on intermittent and you have metastasized disease, be sure to ask your doc, well, shouldn't I get a few days of Casedex before I get my shot? You know, this is Johns Hopkins, and Carducci's the head of the department there, but it just seems very strange to me that they don't do that. That should be.
They've never given me Casedex in the 2.5 years I've been going there.
Yeah. Well, I don't know. I mean, the reason they do it is because the shot that they give you can cause a big surge in testosterone, and if it does that, that can aggravate the metastases, and there have been instances where that's caused issues, and so they tend to give you the Casedex for about 10 days first, so that the Casedex acts as a buffer to prevent any bad side effects from the first 10 or 15 days of the LHRH drug. The LHRH agonist.
Next time I talk to him, I will run that by him.
Yeah.
I hope it's not because, you know, I travel 1,000 miles to get to him, and I'm always up there for 3 or 4 days because I see more than one doctor there.
Yeah.
You know, maybe he knows that I'm, you know, after I see him 2 or 3 days later, I'm on my way back to Florida.
Yeah. I don't know, the boffins who are on the call, does that sound right to you or not right to you? Anybody want to chip in?
Yeah, well, when I was first started on Lupron, I did take Casedex for about, I think it was about a week, maybe 5 days to 7 days, and in spite of that, you know, you have this flare that occurs, and I had acute urinary retention. I ended up in the emergency room with couldn't pee, and they had to put a catheter in, which is pretty unpleasant. So I'm a firm believer of starting some sort of peripheral blocker like Casedex before you go on to Lupron. I mean, that's just my experience.
Anyone else?
Yeah, I'm not a.
Go ahead.
I'm not a doctor. I'm not a doctor, but it seems to me that, you know, whenever you're going to start an LHRH agonist, you're best to start with an antagonist Firmagon first. That removes all the chance of flare.
Right.
Using Casedex, Kosciudex in other parts of the world, or other anti-androgens doesn't always work anyway, and so I think you know, it's been shown to be very safe. You get instant lowering of testosterone. You don't get the problem with flare and the pain that is tremendous pain, which is sometimes associated with it. So I guess that's something to talk to your doctor about as well.
Yeah, yeah, I endorse it. I endorse very much. And was it Dennis or somebody earlier in this conversation got a shot of Firmagon and then switched over to the other drug later on. Yeah, go ahead.
Yeah, Rick, Richard Foodie. When I first started, my doctor, since I was stage 4 and incurable, she was going to put me on a hormone deprivation therapy program. She started me on Casodex first for 1 month to see if my body could tolerate it and the effect on the cancer, and it did work. It did lower my PSA. The second month, we did Lupron only, just to see if my body could handle the Lupron and what impact that had on the PSA, and that lowered it significantly. And then month 3, we started a combination of Lupron and Casodex, and I took Lupron and Casodex for 18 months before the Casodex failed after 18 months, and then she moved me on to Xtandi. So I went from Casodex first, Lupron, then Lupron and Casodex, and then Lupron and Xtandi.
By the way, Richard, there's a new gentleman on this call who lives in Brooklyn, Larry Fish, who's soon going to be using Memorial Sloan Kettering, and I mentioned to him about Donna's class at the beginning of the call. I don't think you were on yet, but I will try and make an email introduction for you guys, and then you can talk to each other later on.
Okay, please do. That'd be great.
Yeah. And Larry,
this is Bill Burns.
Stay here.
I just Bill, I'll come right to you. But Larry, Richard lives in the city, 90th and 2nd or 90th and York. Where are you? Somewhere around there, aren't you? Richard?
Yes, 90th between 1st and York.
Yeah, there you go. So you guys are relatively close, but Richard Foodie knows his way from a prostate cancer standpoint. He really knows his way around Memorial Sloan Kettering. So I'll make a email introduction, and then you guys can go and exchange telephone and what have you. Bill, go ahead.
I was just going to second what Jim Marshall was telling us about using Firmagon to inhibit the flare at the initial treatment rather than Casodex. I also had Firmagon first, and it worked really well, and I've never heard of anyone having a problem with flare having taken Firmagon first, where I know a number of people who have had problems with Casodex.
So, again,
in the U.S., Firmagon is just not used as an agonist, not used very much, whereas Lupron as an LHRH antagonist, it's used a lot. It has a lot of different usages. So I think it's one of these, unfortunately, doctors that are not used to using a drug tend to not prescribe it. So I think it's a good point, though.
Yeah, I mean, and anybody who is on intermittent and is resuming, I would really, I'd insist that the first shot should be Firmagon. If they won't give it to you, then just make sure they give you the Casodex. But if they won't, if they will, then the Firmagon is an idea. And Bob, we'll come to you momentarily and talk a little more about Firmagon versus I haven't forgotten, Firmagon versus Lupron. I just want to finish up with Jim Cameron. And Jim, I mean, let's see if the Lupron does, or the Trelstar does its work and reduces the tumor that they see on the top. I mean, it's probably the best thing to do to start off with.
And there's not much else I can do right now.
No, you certainly don't want to be looking at focal radiation when you're in the middle of all this this treatment. So, but focal radiation may be an alternative, but let's see how it goes. See how it goes.
Yeah, well, I have an appointment. Well, I have an appointment back up there. I think May 31st. So we'll see what happens. We'll see what happens then.
And are you going to test your PSA in the interim?
Yeah, I test in 60 days. He wants me to test it.
Good. Okay, that's good. That's good. All right. So Jay Bob asked us earlier on about Lupron and Firmagon. We talked a little bit about it. The main difference, they do the same thing ultimately, which is they stop you producing testosterone. But there's a difference in how they work initially. One switches off the testosterone right away. That's the antagonist called Firmagon, and there is another antagonist out there. I forget what it's called. And then there are a whole bunch of agonists like Lupron, Trelstar, Zoladex, Eligard, and more. And they work by promoting the amount of testosterone you make to a point where I think it's the pituitary, Steve will correct me if I'm wrong.
Yes, pituitary, yeah, LH and FSH.
And the testicles get overworked and they switch off. They say, we can't cope with this. We can't, we're working too hard, and they switch off. And they stay switched off until you stop the drug. And so there's a risk. Now, that's when you start these LHRH drugs, and that's why we're saying, well, if you start with Firmagon, it's going to switch you right off. It's not going to make the additional testosterone to begin with, which can cause problems, pain, spinal collapse, all kinds of things, depending on where your mets are. But you do that first, and then you can switch over to the Lupron for your second shot, because by that time everything's switched off and it's not going. It's just going to continue along the way. But there's another. There are other tests that have been done, and maybe Jim Marshall can help me on this. But there are men that have found that the Firmagon, all of these drugs work slightly differently, and different men have different responses to these different LHRH drugs. And there is a school of thought that the most efficient of all of them right now, and the best of all of them, and of course it's the most recent, it's been approved for only about 5 years now, is the Firmagon. Jim, do you want to say anything about Firmagon versus Lupron?
Well, I guess if you're in Florida and you're a whole lot of old farts, are we allowed to say that over the airwaves? One of the problems with Firmagon is that it needs to happen every 28 days. And so keeping men on their treatment is harder. It seems to me that some medical oncologists and urologists and radiation oncologists even sort of have an internal clock of 3 months, and so it doesn't fit in with their way of doing it. There is a problem with some of these drugs. Eligard is one, but Firmagon is one, where mixing it and giving it is a bit of a skill, and you want somebody who knows what they're doing. Basically, they're sort of mixing up a two-part epoxy, more or less, and then injecting it in your body. It's not quite that, but you need to have somebody who knows what they're doing. And for Firmagon, there are some very clear instructions in videos on the web and from Snuffy Myers of getting the angle right and where you put it in and so on. Another issue is pain. the injection itself causes no pain at all. Much, you know, if you've got a skilled doctor, it goes in neatly, and you think, oh, that was easy. Not as big as that, you know, grain of rice that they put in with that horse-sized needle for the Zytiga. But then in the next few hours, a histamine reaction sets in, and that comes out as a red patch on your belly, and pain is initiated. As with all these treatments, for some men it's more than for others, and some men choose to give it up and go back. A mate of mine here stuck with it for 12 months. Myself, although I was on Zytiga and Casodex for the first 4 years, then I had a break of 2 years. But since you know, when the cancer occurred, I went back on Firmagon, and I'm staying on Firmagon. But that's almost a month-to-month decision, because I'm one of those who finds it quite painful, and the histamine reaction is fairly strong. The reason I stay on it is with my comorbidities, a lot of treatments aren't available to me as time goes on. So I want to get the best I can. Firmagon, there's no clear evidence that it's any better, but there's the sort of things we should be ignoring, like rats and test tube evidence. But the rats and test tube evidence suggest it may be a bit better for your bones, and it may be a bit better for your heart. So that's one reason that I put up with it. Any questions on that?
Yes, I agree with almost everything that you just told us, Jim, except for I think the evidence is actually now pretty clear that Firmagon is superior to Lupron in its different formulations in terms of how well it knocks down testosterone. So I argued vociferously with my oncologist for about a year to stay on Firmagon instead of switching to Lupron, because these studies show, for example, that Firmagon has anti-angiogenic activity that certainly would be helpful in terms of you know, thinking about keeping tumors from growing. It's by anti-angiogenic, I mean that it stops blood vessels from growing and you know, providing a blood supply to the tumors. The only so the argument that my oncologist gave me was mostly based on the fact that the papers that show that Firmagon is superior to Lupron were all published by people that they thought were contaminated by conflicts of interest. In other words, they had ties to the company that produces Firmagon. But I think that's a weak argument, and I really think that that the you know, there's enough evidence that it's superior to me to have put up with the 28-month or 28-day cycle for a year. I eventually stopped because I got tired of arguing with my oncologist every time I went in to get my shot, and the 28-day cycle is you know, for somebody like me who travels a lot, it just became too difficult to stick to.
Yeah, I agree. I think that doing it every 3 months versus every month is not a small deal for me. And you know, myself, and you know, when I get that Lupron injection, I mean, it really gives me some pain for a few days afterwards. So doing it every month would be a big deal. It'd have to be significant evidence. And you know, as a gynecologist, I used to hand out Lupron like crazy because we treat endometriosis and we treat fibroid tumors with it, and there was a strict rule that you didn't continue it past 9 months because it, you know, the lowering of the estrogen levels, which would be similar to testosterone levels here, you know, can cause very significant osteoporosis. You know, we used to actually use add-back therapy with estrogens and so on. So, you know, being on it for a long time, of course, is always worrisome from the standpoint of osteoporosis, both drugs for that matter. But, you know, it's all on the big scale of things. It's like, you know, you got to you pick your poisons, so to speak, I guess, huh?
Yeah.
Okay, Jay, does that help you? Go ahead. Who was that?
This is Rich Anno. I was on Firmagon for 5 years. I had to come off it because of the scar tissue. They had a hard time getting the needle in anymore. Because of the lumps it causes. It leaves lumps inside your stomach. Yeah. And they discontinued it because the nurse was having a hard time putting the needle in.
Wow.
I can understand that. I haven't had a Degarelix or Firmagon shot for 2 years now, and I can still feel those lumps.
Yeah. And whenever you get X-rays or CAT scans, they'll come up. They'll show you where you could see it on the CAT scan where the injection was, and
right. That's not a problem though, but as long as a radiologist knows how to interpret that.
Well, it becomes a problem when you can't get the needle in.
Yeah, that is a problem. Yeah.
I just thought a lot of people, if you're not on it that long, I don't think you get that much buildup. But I didn't know myself, and when I talked to my doctor about it, he said, "Yes, I know this is happening. I spoke to the company about it, but evidently there was nothing they can do."
Yeah.
Thank you, Rich. I haven't heard that before.
Jim here.
Yes. Go, Jim.
Jim here. I keep a map so that the injections are well spread either side, up and down, and middle, and so on.
Yeah.
It wasn't actually for the reason of the lumps. It's because I've had previous surgeries and I've got sort of stainless steel mesh up the middle of my belly and so on. But having heard your comments in an earlier phone in, yeah, I keep the map.
That's true.
Okay. Well, guys, we're over our time limit. Has anybody joined us that we haven't acknowledged? Is there anyone on the call that we failed to acknowledge?
I'll have to go.
All right, bye, Jim.
Good night, Jim.
Go. We are, if not, we're going to wrap this up. The next call will be next Tuesday at 6 o'clock Eastern, 3 o'clock my time. You can, of course, listen to the call again and visit the website. You'll find the call posted there in about 2 to 3 hours. And I will try to follow up with all the different connections I promised to make. If you don't hear from me by tomorrow sometime, send me a note and remind me that I forgot to do something. And I think that's about it. Oh, I do have one question. Did anybody listen to that interview that I suggested in the notice, the NPR interview?
I did not, but I'm planning to. I just haven't had the time.
Okay. Well, it's only.
I remembered it when I logged in tonight. I saw it again, and
it's only 7 minutes long, but it's a very nice interview. I suggested if you haven't listened to it, it's worthwhile for 7 minutes. All right, guys.
Okay.
Say good night to you all.
Good night. Good night. Good night, everybody.
Good night, Rick. Thank you.
Good night.
Bye, everybody.